for those of you that are really awake, you'll notice I've changed my top, okay? And I'd like to wear this top everywhere, but people look at me funny on the train. So I save it just for these events. And the reason I wear this top when I'm presenting about this is because I want us to remember that infection prevention and control is getting more and more important in the days now that we're facing antibiotic resistance. A few years ago, someone got an infection, there was always antibiotics. Now there's not. And now it's more and more important to, be really on the ball with our infection prevention and control, and to recognise that it's not just in the scope of hospitals. There's, infections out there that are antibiotic resistance in the community, and so we need to be on it. So that's why I wear my lovely top to do this. Okay, learning objectives, basically that you're going to understand the nurse's role and the adoption of management processes and development of infection prevention, practice policy, and, okay, effective infection prevention and control is central to providing quality healthcare for patients and a safe working environment across all healthcare settings. Well, that's probably one of the most important statements of the whole session. And I think this module helps nurses working in general practice to understand safe and effective infection prevention control in the primary care setting. There's often an assumption that sick patients are in hospital, but actually sick patients are out in the community as well, and especially nowadays more and more immunosuppressed patients. So, and in the primary care setting, you are really the frontline person, and you're also the frontline service where most people go. They don't go to hospitals and A&E departments much anymore. They come to your GP service with these infections, and you're the first point of care that needs to know what you're looking at and know how to manage it so that you're not spreading that on to other people. Okay, so I always think that this slide is really about what to do. What do you need to do and how do you do it? So look, we discussed this as an accreditation requirement, but how does infection prevention and control really look in the primary healthcare setting? One of the challenges is we were all taught our infection prevention and control in the hospital setting and what to do in the hospital setting. And it's quite easy, isn't it? There's a committee up in the hospital setting, or even in your aged care facilities, there's a committee that says this is how you do it in the hospital and the aged care. They're all very similar. The processes can be standardised. But in general practice, you're going to find there's no one size fits all. Services are different. The type of clients they see are different. The facilities are different. So there isn't a one size fits all. Now, to help you with all of that as much as possible, there is a book brought out by the RACGP called Infection Prevention and Control. There's a picture of it over there. This does help convert those standards that are written for the hospital setting into what you would do and how you would implement them in a primary care setting. And that's mostly what we're going to talk about today, really. But this is a challenge for you working in primary care, is how do you transfer the knowledge you acquired in your nursing course, the knowledge you've acquired since working in the hospital, to the new setting of primary care and whatever your individual context might be. So that's what we're going to talk about today. Okay. So obviously, to be able to make a difference, to be able to do things, you need to have certain enablers. And we're going to talk about what needs to be in place in your workforce and your workplace to be able to let you implement infection prevention and control activities, because there's nothing more frustrating than feeling like going to your service and seeing things that you don't think are done correctly or aren't done safely, and then making a suggestion about it and being shut down. It's very frustrating, and it's important to have some insights into why that might be. I'll give you an example. If you were to go to your service and say, look, I really think we need to be using sterile gloves on every procedure we're doing because that's what they do in the hospital, I'd be pretty sure you'll get shut down. But if you go to them and say, I think we should be using sterile gloves on this, this and this procedure because of this, this and this, and you're actually using the right enablers and the right reasons, then you're more likely to get some traction for your ideas and actually affect some change. So let's talk first about, to actually get people on board, you actually have to create a culture in your workplace where everybody is on board with infection prevention and control. It might mean you have to wear a t-shirt like this to work just to make them aware of it, or it might mean that you just need to talk about it. You need to show a bit of passion, help remind people how important it is, and get everyone engaged and committed into infection prevention and control. And of course, the other things that you need in your environment, you need to have access to your local networks and training to receive updates and things that are coming. So you need to be able to be logged on and receiving that. And that information needs to be communicated through your service so everybody's engaged with it. No point you just getting information from the health officer about the latest updates without having a process for passing that on. And if that process is happening around the doctors, ask the question, well, why isn't it being passed on to the nurses? You know, and this sort of thing. So you need to make sure that that information is conveyed and shared. And then everyone will read, there's an alert coming out about measles, then they'll actually think, right, well, what are we doing about it? It actually helps keep things relevant and people realise that they're not just working in their own little bubble, they're part of a whole, a broader community of infection prevention and control. You need to have infection prevention and control as standard items on your meetings, standard agenda items, so it's talked about regularly. You need to make sure you've got good resources around and keep changing those resources and make sure that you've given enough protected time or human resources to do what you need to do around infection prevention and control. You know, that then actually validates that this is an important activity. And you need to make sure you've got adequate equipment, and you need to make sure that your physical environment, that the service that you're working in actually is set up as well as it can be, and that you know, if you're, I don't know, I used to go to medical practices where nurses were like having to wash instruments in an old sink out the back. You know, if that's your situation, you'd be saying that this is just not good enough. We need to actually put some money into getting these environments where it's actually can be managed properly. And if you want to sell ideas and get ideas in, it's really important to be able to, because you're working in primary care, they're small businesses, they do run on making a profit, most of them, so you need to know the business cases and you need to be able to talk the business talk to get things changing. So who wants to suggest some of the business reasons why infection prevention and control is important? What's the damage to the business if you don't apply it? Like an example is infections can cause hardship for patients and their families, so and increased pain and suffering. So if a patient gets an infection at your service, that doesn't look good for the reputation of the service. So there's a business reason for why you might want to argue that here's why we need to do something about infection prevention and control. What other reasons are there that, you know, practices don't want to get infections happening there? What's some reasons for it?
They may just not want to come back, so you lose money.
Yep, the person may not come back to that service. Like my husband had a mole removed somewhere, got an infection, said, I'm not going back to that practice. I said, you might have got an infection anyway. He said, I don't care, I'm not going back there. So, you know, that's what happens. So, you know.
Could get an infection and then it affects having to have time off or...
Yep, so work cover, you know, if you haven't got good infection prevention control and all your staff come down with influenza in 1 week, you've got some problems with, you know, with that. And if you get something more serious like Hep B or Hep C or something like that, then you have got a massive work cover claim. So yes, work cover is a good business argument. Any other reasons?
Could get sued, or someone could go to like a current affair or something like that.
Yep. Could have a current affair chasing the doctors to their car in the car park. I just want to ask you a few questions. What else could be going on? What about the cost of your wounds that get infected? The cost of dressings. And these people are coming back getting multiple dressings. That's a cost of the service because really it's pretty hard to claim the cost of dressings and consumables. So there's a pretty good one. Anyone else got anything else? We've covered most of them. I think the other one is just your community expectation and what your peers are going to say about you. So, you know, if doctors don't want it out there that their peers are going to say that surgery has a problem with infections and not good management. So that's often a very powerful motivator as well. Okay. Now, remember we said that there's a person with leadership responsibilities and that person should have those responsibilities delegated via a position description. This list is the sort of things that exactly should be on that position description, and we're going to talk about what each of those looks like in more detail. So I guess the roles of the person with leadership responsibilities for infection prevention, and just for the sake of this, pretend it's you because it might not be you right at the moment, or it might be, but in the next job you go for, or as you want to get promoted and go for other jobs, you know, this is a role for nurses, it's a senior role for nurses in practices, and it's a good way to advance your career and take yourself into something that actually really has a say in the administration and business of the service as well as the management of it. So some of the things that are your responsibility, if you are the person with designated responsibility for that, is obviously accreditation and writing your policies. Your staff health and safety or work health safety, education, Surveillance, and I'm not talking about surveillance where you wear a trench coat and put on some sunglasses and have binoculars in your pocket. I'm talking about the infection prevention and control surveillance involving your patients and their families. You can tell these things are written for the hospital, partnering with consumers. That's like another language in general practice. What we're talking about is your patients and their families. We're talking about preventing and controlling infections. So that is basically just a brief revision of your basic nursing 101, infection prevention and control, and how that looks in a general practice setting. Risk management, and then getting the evidence, making sure you've got the evidence and you're making evidence-based decisions. So let's start off with the first one, accreditation and quality improvement. Generally, we've talked a lot about accreditation. We're not going to cover that, but we are going to talk about one of the main activities that you will be asked to do, and that's writing your policies and procedures around infection prevention and control. And also perhaps doing audits. But there's a big long list in the accreditation standards and in the infection control standards nationally, which they all link into, about what you must have a written policy about. I'm not going to read it out, but it's pretty much anything to do with infection control. You need a written policy about it, and it's all in the guidelines. It's also listed in this book, the list of everything you need a written policy for. So you use policies to meet accreditation requirements, but they also get used for training new staff. I don't know how many of you, when you just started, were told where your policy and procedure manual was, and then told what to read it, or told have a read of certain things. It would be good if you haven't been told that to actually find out and do that. And then it's also used to maintain consistent work practices, and that's really important in infection prevention and control because, you know, when we get down to talking about, you know, breaking that cycle of the chain of infection, if you haven't got consistent practices and one person actually isn't doing something to break that chain of infection, then the whole lot falls over. It also informs and guides best practice, and it also provides links and references and other places to go for more information. So, just to get us thinking about what we might do if we were going to be writing a policy, imagine that you've been asked to write a policy around hand hygiene for your organisation, okay? And hand hygiene is one of the few things that isn't a whole lot different in the hospital setting to what it is in the primary care setting. And it's also probably the number one most important infection prevention and control activity you'll do. So if you're going to write that policy around hand hygiene, what's one of the first things you'd be wanting to do? So what do you mean by that?
So you'd have all your hand hygiene things. You've got your basins, you've got your paper towel, you've got them accessible in places where they're going into the patient and out of the patient, in places that are just easy access.
So in your policy you would say this is the products that we use, okay? And the products that you should be using in primary care, they're not complicated. They want to keep them as simple as possible. Don't let a rep come and try and sell you some brand new expensive product because it's often not needed in primary care. They try and keep all of their products simple. So usually a 2% chlorhexidine based soap is sufficient. A 4% chlorhexidine based soap in your treatment areas where you're doing procedures is good. Any alcohol rubs that you've got need to be at least 70% ethanol. So all those products can't be products bought at the chemist. They need to be commercial medical grade products. Then you talked about your physical environment. So your policy would touch on your physical environment, making sure that you've got things where you need them and that your policy says, you know, we have some hand rub available at the reception area and we have it available in the doctor's bags and we have it available here or whatever. In our physical environment, all of our treatment rooms have access to a basin, and where these procedures occur, we have this. So you talk about whatever your physical environment is. And then I think what other things would you include in a policy if you were writing it around hand hygiene?
Is there a national hand hygiene link now, isn't it?
Yeah.
To do a competency?
Yes, that's right. So you can go online and do the hand hygiene competency. It is, and most of you, if you've been in the hospital, you will have had to have done that and got your little tick of approval for it. But it's useful. You can put a link in your policy about here's where new staff could watch this, or reception staff. They won't have done hand hygiene before, but they're still part of the team. So maybe reception staff would benefit from watching a little hand hygiene process. And you would also then summarise the correct technique and those 5 moments for hand hygiene. And you'll notice that the hospital one, it's got the person in the bed with the catheter and all this sort of stuff. They did try and adapt it for primary care, and they've sort of got someone sitting in a chair, and it's a little bit different. If you can find those images that are not so hospital based, that's better. What else would you do? What else would your policy include if you're going to write a policy about it?
Definition of hand hygiene.
Definition of hand hygiene, yes.
And why.
Yep. Yep, so why? So that's really your policy part more than your procedure part of writing it, that's right. What about if you're going to do audits, or whether you might do audits? Would that go into your procedure, that we do an audit on hand hygiene, or how you do it? How do you think you would do an audit on hand hygiene in a general practice? You can't have someone like the hospital, you haven't got the resources to have someone like the hospital going around checking you're washing your hands properly. How do you do an audit on hand hygiene in primary care when all the doctors are in their own rooms? You don't know if they're washing their hands before or after they see a patient. You might be able to watch them when they're in the treatment room and sort of say, hey, before you do that procedure, you really probably should wash your hands. But
Do that, sorry.
yeah, what was that? What were you going to say?
Sorry.
Mm.
You know the light, you know,
Yep.
above?
So you could ask them to wash their hands and put the light on their hands in a meeting. That's always good fun, and that's really meaningful, especially for reception staff that have probably never seen that before. Helps them realise that you need proper hand washing. It also then starts to talk about technique, and it talks about jewellery and rings. Should you or shouldn't you wear rings, and what it looks like when you do or you don't, and false fingernails, etc.
Incorporate them to do the competencies, whether it be annually or biannually or whatever.
Yep. Involve them in that. That's right. Involve everybody in it. Yep. And the other audit, that's a simple one to do, is just have a look at how much soap a doctor's using in their rooms. Okay, so just put a little line on the chlorhexidine bottle. See if it actually goes up or down in a week, and if it's the same as somebody else or not, And I suppose if you bring them out on that, then they might pump a few pumps into the sink. But no, not really. It's just a good way of seeing, is it actually being used? Do they wash their hands? It's an easy way to tell. And then after you've written it all, what do you want to happen with that policy? You don't want that policy to sit in a folder and be used to prop up someone's computer monitor so it's the right height for them to look at. What do you want to happen with that policy?
Send a memo out.
What was that?
Send it out in a memo.
Yeah, you want everyone to know about it. So you would send it out in a memo, you'd send it around. You'd probably engage people in the process of actually writing it so that they're kind of not feeling that it's being put down on them, that they're actually involved in it. What else would you do?
And you review it?
Yep, you'd have on there the review date and how you're going to review it. The other thing that you do is, remember I said that infection control, it involves everybody in the practice, but it also involves working with your patients and their families. So you've somehow got to make it relevant to patients and families, because there's no point having the staff washing their hands brilliantly if the patients aren't. So you might do things like this, and there's heaps of them. There's posters all around that you can put up that remind patients and staff to wash their hands. How to use hand rubs. They'll just go online and Google them, you'll find them. There's a little bit of an adaptation of your 5 moments for hand hygiene. Stick them up around the place, and then you've got them all there for to help keep it in people's mind and actually keep it active. So there's quite a bit, that's one policy, and there's probably a list of about 10 different things you need to write policies for. But hand hygiene is probably one that's really important, that you do follow a proper process and get everyone involved with it. Okay, staff work health and safety. This is another role that you will have if you're in charge of it. Let me just ask someone, because I think this is really important. Staff immunisation. You've all just started your jobs. Was there anybody here who was asked what their previous immunisation status was like, and recommended that they went and got immunisations if they hadn't had it? So someone's nodding. Anyone? Show of hands if you were asked that.
And immunology.
Yep. Yeah. So that's really good, but it's really important that you are asked that, because it's one of the most, it's so important that they know what vaccinations people have had in your service. And as we get further through this, you'll realise why it's important to know what vaccinations. It's also important to know if people have any characteristics that make them at risk. So are they on any immunosuppressant drugs? Are they pregnant? Is there any reason that they haven't had a particular vaccination, and have they declined to have it? And you are allowed to decline to have it, but that needs to be noted on your work file. So you're obviously responsible for documenting and maintaining those records. You'd also be responsible for provision of adequate equipment. And I would think that any equipment that is to do with likely to be used by a nurse, then nurses should be involved in the purchase and selection of that equipment. So make sure that, you know, if they're talking of buying something, you're saying to your manager, hey, I'd like to have some input into, you know, the products that we're looking at too. You'll be involved with looking at your safe sharps management, and obviously, again, what sort of things will we be doing about safe sharps management? What would we be looking for? You know, obviously we're talking about sharps containers and that, but this is more you'd be involved in purchasing equipment. So what sort of equipment are you going to be looking at for safe sharps? Retractable needles wherever you can, handles, containers for carrying sharps in, all of that sort of equipment. That's right. And so you'd be involved with looking at that. The management of occupational blood and body fluid exposure. Again, there's another policy you've got to write, but you need to make sure that whatever you're recommending in that is actually in line with the current practices. There's, it's useful to, again, put up some posters around that. Nobody gets needle stick injuries very often, but when they do get a needle stick injury, they usually like to know straight away what to do and how to action it. You don't want to get a needle stick injury and then take half an hour to find out what you're supposed to do and who you're supposed to contact and whether you wash it or whether you don't. So again, you can write whatever you like, but there's lots of online ones that you can get as well. You would have seen them in the hospitals around what to do if you get a needle stick injury. And then, as I said, you need to be the person who knows which staff might have increased risk and have had a discussion with them about what the management would be. And, you know, the implications of a casual receptionist who refuses to have a flu vaccine would probably mean that you actually don't get them to work over flu season. You know, so they need to understand that, you know, so there's the things that you need to talk to them about. So. Did you refuse to have a flu vax?
Yeah, I refuse every year.
Yeah, and do they say anything to you at your practice? Yeah. So as long as they, you know, as long as there's an understanding that, you know, that you've agreed that, it's been documented, you've agreed it, they've offered it to you, then you can't go back and say, hey, I've got these major complications from influenza that I caught at work. They've protected themselves. You know, as long as that discussion's been had, that's okay. But it's around having those discussions to protect the workplace. Okay, education. You're responsible for making sure that there's an embedded program for all clinical and non-clinical staff. And don't forget with your education, when you're perhaps having a meeting and you're getting someone in to talk about perhaps infection prevention and control or sterilisation, that you involve your cleaners and your other staff. And that's the same with your vaccinations as well, that you involve your cleaners that come in. Make sure they've had their Hep B vaccinations. Make sure they understand what to do if they come across something that's contaminated with blood or body fluid while they're cleaning. So it's got to be, it's not just inside the practice, it's the staff, it's the patients, and it's those other staff that are contracted to come in and do services. Okay, so obviously all your training needs to be tailored to your service context and what people need. So what you teach a doctor or what you might offer to teach a nurse might be quite different to what you're going to teach reception staff, because no one wants to hear something they've already heard over and over again. Good to just remind it, but you don't want to be having a standardised approach. And a lot of this stuff can be accessed online. So it's easy just to say to people, here's some online courses, just do it and sign off that you've done it. So you don't have to actually take a lot of time to do it. And you know, you need to be offering education around hand hygiene, your standard precautions, using personal protective equipment especially, managing blood and body fluid spills, how to clean it up, what to do if you get a needle stick injury or exposure, safe use and disposal of sharps, environmental cleaning, reprocessing medical equipment if you sterilise on site, and if you don't, even if you have to wash items, how that's done properly, and what to do in the event of an accident or incident, and what classifies as incident, and where to find information. So there's quite a lot of education that's involved, and it requires a bit of tracking to make sure that you've tested someone's competency, worked out what they need, and then you find a chance to provide it. Surveillance. Okay, so what we're really talking about with surveillance is looking outside your organisation at what's happening in the big world. It's easy just to think within the confines of your general practice, but infections don't stay within the confines of one general practice. Infections run across the whole community, so you need to look at what's happening outside your services. And sometimes it's only by looking outside your service that you actually see trends that help you recognise that you need to implement some risk management. I'll give you an example. Years ago, when I was working for a body which is now your PHNs, but in those days they were divisions of general practice, I had a couple of nurses ring me and say, hey, we've got these people coming with these horrible ulcers and wounds and they're really hard to heal and all that. And anyway, they went and got them swabbed and they came back for community-acquired MRSA. And one nurse has rung me from one service and one's rung me from another and I was getting a couple of calls. So I put something out in a newsletter. Is anyone seeing increased incidence of these ulcers, you know, and you know, possibly are community-acquired MRSA? Here's some information about it. Anyway, by just putting that out, they actually all started to talk to each other and we realised that the source of that infection was coming from the local rugby team where they were all having their showers together and sharing towels. So by actually working together as a community and having some surveillance over the sort of area, we're able to work out this is where it's coming from. It's mainly in this community, and as an organisation across all the GPs, do something about it. Now, those sorts of infections don't ever hit the hospitals because they are something that's dealt with in the community sector. So, you know, just a little bit of education. We've got a doctor to go and talk to the boys at the rugby club about proper shower hygiene and solve the problem. So, and obviously everyone who had ulcers wasn't allowed to play and this sort of thing, and it solved the problem. So this is where surveillance is really important. So surveillance involves obviously, you know, looking at detecting and monitoring your diseases, but then it's also around assessing the risks and how they impact on your organisation, and then it's also about evaluating what interventions you need to do, if any, and providing information to the staff and to your patients and their families around what that might look at. So some activities around surveillance, and there's quite a few. Reporting notifiable diseases. Has anyone had a chance to check out the Notifiable Diseases website? It's probably something that you should stick on your Google favourites, just so that you can find it, and if you do need to notify something, and just follow up. A lot of doctors can be a bit relaxed about notifying diseases because it takes 5 or 10 minutes and they're too busy, but you know, that's important that they do notify diseases. So, and sometimes even if you don't notify a disease, it's sometimes hard for the patient when they go to the chemist to get their medication. So like say shingles or something that needs to be notified, sometimes without it notified they can't get their script on a cheaper rate and things like that. So, and then the other thing is monitoring external threats and outbreaks, so emerging diseases. Places where you can get that is by registering to get your PHN newsletters if there's any, and registering with your state health department. All health departments have good information going out about that, registering to receive their newsletters and checking, you know, listening. You might have heard there was a measles outbreak in Melbourne not long ago. I think it was something in the paper about being at the airport on a Wednesday a week or two ago or something like that. You know, you have someone come in that looks like they might have measles, then you might ask that question, you know, have you been overseas? Have you been through the airport recently? You know, and I've heard there's an outbreak there. So it's about being aware of what's happening in your wider area. And then the other thing that surveillance is about is identifying any presenting infectious diseases. So obviously that's a big role of reception staff. And it's important that staff respond rapidly when someone does come up with a suspected or confirmed infectious disease. So that's around your triage, but it's also making sure that when you, like measles is a good example, say you've heard about this measles outbreak in Melbourne, you might actually send something around to your reception staff saying, did you know, and your doctors, did you know that this was in the media, that there's been a measles outbreak? These are the symptoms, just to remind people so that if someone comes in that looks like they might have measles, it's actually in their mind, hey, this actually could be measles, it's going around at the moment, or, you know, and I'm not sure if you're aware, but if you do have the misfortune of having someone come into your waiting room in general practice with measles, it is a huge job. It'll be the biggest headache you've ever had. You actually have to trace all the contacts that are in that waiting room at the time and within a couple of hours after that person's been there. Then you have to call them all in. Then you have to assess their vaccination status, and then you have to make sure that you give them immunisations or other immunoglobulin if they need it. So it's a massive job. So, you know, and often you hear of practices where somebody came in with measles and it was just, you just got a virus, go home. So they've come back the next day. So you've actually got 2 days of tracing and tracking that you have to do. So it's much better if you had to pick that up the first time than the second time. And it would have been much better had the person read something, I don't know if I've got any here, but you can put up signs. Oh, there's a bit of one. Have you been travelling overseas? You know, do you have a rash and a fever? Please tell us before you before you come in. If you're making an appointment, please tell us, or tell reception when you arrive, so you can actually put that person in a room by themselves and not sit them in the waiting area. And then that makes your whole job a whole lot easier. So, you know, so being aware of presenting infectious diseases is really important, and also having systems in place to trace the contacts, being able to retrieve those appointment lists to see who was in a waiting room between these hours on a certain day. And it's worthwhile doing a bit of a practice run of that, just rather than actually having to wait till the real occasion. Just say, hey, can you just tell me who these people were, to see if you can actually retrieve that information easily. Because you might get who's in seeing your doctors, but what about if you've got allied health using your rooms as well? Are you able to track who was in to see the psychologist that's got a room down the corner? You know, they're still someone that needs to be traced and followed up. Education about travel vaccines and putting signs up and informing patients of their responsibilities around any infectious diseases, but travel's a common one. And then looking at process surveillance. So that's looking at what you're doing. Does it align with your guidelines and policies, or do you need to change what you're doing or change your policies? And accreditation is often an occasion when you do that. The other thing, other sort of surveillance, is critical incident surveillance. So when you have an adverse event, if that adverse event involves an infection or something like that, then if you're the person with responsibility, you should actually be notified of that and involved in that process of looking at that, and not finding out about it 3 weeks later when it comes up at a meeting, but finding out about it when it's notified. And looking at near misses, and you might do a look-back investigation. An example of that is, you know how we talked about recording and tracing for your sterilisation processes? The reason you're doing that is because if there is ever a breach, and believe me, I used to see lots of breaches in sterilisation in general practice. Often the most common breach was that people had sterilisers where you could select different processes, and they were selecting the unwrapped process instead of the wrapped process. So they've probably been sterilising for the last month on as wrapped instruments as unwrapped instruments, which means the temperature's not hot enough to actually sterilise the items in the bag. So technically they should do a recall of that. Lots of services wouldn't bother, but they should, and they need to go back and trace who those people are and call them back in, and that's what that tracking and tracing is about, and that's what you call a look-back investigation. Then of course there's promoting antibiotic stewardship, and then there's population screening. So that's more big hospital stuff, but it's still relevant to looking at your wound infection rate, or looking at your, post a particular procedure or something like that, just to track, if you want to do some audits and you're motivated about it and you've got time, then that's probably a good one. And then obviously integrating with your established programs. So a lot of GPs can nominate to be involved in the state influenza programs and things like that, where you actually report your cases of diagnosed influenza to help the state track what the trends are in influenza and what the infections are. So there's quite a lot to surveillance. The next thing to do is partnering with your consumers and your patients. It's really important that the experiences and views of patients is not something that's bolted on after you've made the decision. That actually, when you're making decisions about what you do, part of the process is that you consider, where does this involve patients? How does this impact on patients? What do we need to do for the patients? So it's like when you're doing a hand hygiene policy, as you're thinking about that, think about, right, what posters am I going to need? How am I going to educate consumers? It's just built into the framework, that the lens that you look at things through. Because especially with infection prevention and control, if you don't include the families and the patients that are coming there and their broader community, then you're not really affecting very much at all. So if you have someone come in with infection, your advice automatically needs to think, is there any school exclusions? Is there any work exclusions? These people aren't in a hospital where you've got them in a room with a shut door and a sign on there and you can really control and maintain it. These people are coming to see you for an hour, but living the other 23 hours of every day in the community. So you need to think about the impacts of infections outside the community, outside your practice as well. So that's about why it's so important to encourage their participation, both while they're in the service, encourage their participation in, why they need to wash their hands, encourage their participation in proper cough etiquette and all this sort of thing in winter. Put these posters up, but also think about it when they're outside, and provide information for patients that is obviously signage on the walls, but things they can take home at certain times. Okay. Now we're going to get on to Infection Control 101. So I'm going to actually be asking you most of these questions because we're all nurses, we've all learnt all this, but for some of us it might have been a few years ago, so this is just a bit of a refresher on what you might have done, just revise the basics and how they might look in a primary care setting. So as I said before, the aim of infection prevention and control is to break that chain of infection. Okay, you want to interrupt the mode of transmission, so this is what we're really aiming to do. So to interrupt the modes of transmission, you actually have to know what the modes of transmission might be to know what you need to do. So who wants to go through these? Who wants to tell me, can they remember what contact transmission is? Who wants to tell me?
Coughing on your hand and then having a handshake with someone.
Okay, so that's an example of it, yes. So what are you doing there? Why is that contact transmission?
Passing on the bacteria by touching a surface or touching another.
Yep, so that's right. So contact transmission is passing it on by touching contaminated surfaces. Who wants to have a guess at what sort of pathogens, one or two, that are particularly very good at being passed on by contact transmission? Your gastro, so your noroviruses, those sorts of things. Anything else? Yep, your MRSA. So they're your common two that come up. Okay, what about droplet transmission? What's that? Coughing? Yep. Sneezing. Okay. So what's with droplet transmission? It's large droplets. What's the radius? You know, what's the kind of given, if someone's coughing and sneezing, what's the sort of distance you would want to be away from them? Ideally the other room, but I mean the minimum distance.
For the droplet, it'd be close, but for the actual airborne transmission, that's where it comes into the separate section. The airborne's a bit further because it can continue further, but the actual droplet is a bit smaller.
That's right. It's about 1 metre. Okay, so you know if you can sit someone who's got who's coughing and sneezing with droplet transmission about 1 metre away, that's the minimum sort of isolation. Obviously further's better. Okay, who wants to have a guess at something that is transmitted via droplet? Influenza, yeah. Anything else? No. Measles is airborne.
You could probably go with Hep C or Hep B with the blood
Yeah.
droplet.
Yeah, no, we're talking about droplet. Usually it's from,
Just the
nebulizers or coughing and these sorts. Mainly viruses. But you've got your pertussis, that's a common one, and SARS and all that. Well, we're not going to worry about SARS too much. And of course, what we're realising here is a lot of these are transmitted by more than one mode of transmission because pathogens are really smart. They don't just stick to one mode. A lot of things can be transmitted by droplet and contact transmission. Okay, airborne transmission. We know that's smaller particles. You said before they float from room to room. What's a classic airborne transmission pathogen? Well, sorry, what was that? TB, yes, that's one. What about another one? We were just talking about it before. Oh, you're thinking about Legionella's disease? Yeah. Measles. Measles is the most common one that's airborne. That's why it's so hard to manage and control. You know, you think about it, measles, you've got to trace everyone that was in that waiting room because it's airborne. It goes everywhere. It doesn't just, you don't have to just track everyone that was a metre away from that person. It's everyone that was in there. And airborne transmission can often remain after the person's left the room because the particles are so small and light. They can actually remain there after the person's gone. Then we get into some of the more tricky ones. Vehicle transmission. I'm not talking about automatic and manual here. What are we talking about? What would be...
needle.
Yep, so it's... Well, it's generally, yes, it could be that, but more often than not, it's through contaminated water or a multi-dose vial or something like that. So it actually goes into something else which then carries it. So a needle can be the vehicle that's transmitting it. And vector transmission, mosquitoes. So that's anything that, you know, those Ross River malaria, those sorts of things are transmitted by there. So it's mainly the top ones that are relevant to what we do in general practice, but if you're in a lot of areas, you'll come up with Ross River if you're working in areas along the Murray and all that, but it's actually not a lot you can do about keeping mosquitoes out of the general practice, but the other things you can do a little bit about. So, okay, so how do we prevent and control and make sure that we break that chain of infection? We use two sort of things. We've got two tools we can use. One of them are standard precautions, which we all know are just your basic level of infection control. You do it all the time, it's routine and it's applied universally. The other ones is transmission-based, which used to be called additional precautions. And as the name suggests, you only do those when there's a known or suspected pathogen or infection, and you implement the appropriate transmission precaution based on what you suspect the pathogen to be and based on what you know will break the chain of infection for that pathogen. So if you suspect it's a pathogen that's spread via droplets and contact, then you would implement contact and droplet precautions. Okay? But we need to look at what contact and droplet precautions mean in a general practice. You know, you'll see it in the hospitals all the time, standard, transmission-based precautions in place. Do not enter the room, do this, X, Y, Z. The Infection Control Committee tells you what to do. In general practice, you actually have to know what to do and have those processes in place so that this is the precautions we implement for influenza, or this is the precautions we implement for MRSA, these sorts of things, so that you already have it planned and you know what they are. So let's talk about some examples of standard precautions. Who can tell me what they are? PPE. Yep, PPE, that's a common one. What else? Hand washing. What else? What else is there's precautions and things that you do standard? What about? What was that?
Cleaning area.
Yep, so environmental cleaning. Yep.
Waste disposal and sharps.
Yep, waste and sharps disposal. There's rules and regulations which sharps go in which containers, how you dispose of them, what you do. That's right. Anything else? Linen can go into your disposal as well. You're using linen and how you handle linen. Anything else?
Decontamination, disinfection.
Yep, so decontamination, disinfection of the environment and of instruments and things like that you might be using. And another one, I had a poster for it before. What's this one? Cough etiquette. Okay, it's one of your standard precautions. And aseptic technique. Remember that first time you had to do that dressing and you were so scared that you might, do something wrong? Well, that's a standard precaution. Okay, so as I said, your transmission-based precautions are used when there's a known or suspected infectious agent, and we know that it may include one or any of the following. So who wants to suggest what some transmission-based precautions are that we do? Isolation, that's one, yes, probably the most common one, isolation and distancing of patients. What else do we do? It's the same one as you use for standard precautions, you just ramp it up a bit. Who wants to know? PPE? Yep. So that's right, you just wear different PPE, but it's still PPE. What else do we do for transmission-based precautions?
You isolate the waste as well.
So you minimise you will provide dedicated equipment, and so I suppose waste is managing their waste, but it's also dedicated equipment for the patient. Really hard to do in primary care, but you can try. Other one is cleaning, but you use a two-step cleaning process, so it's a slightly different process. Rather than just cleaning, you actually disinfect as well, whereas surfaces might only have normally been cleaned, and you restrict the movement of health professionals around and the number of health professionals having contact, so it's a bit like that distancing. So as you know, contact precautions, as the name suggests, are used for someone when you think it's a suspected infection with something that is transmitted by indirect or direct contact with contaminated surfaces. Droplet, used for patients when they're known or suspected to be infected with something that it can be transmitted over short distances by large respiratory droplets. And airborne precautions are used for known or suspected patients to be infected with agents transmitted by the person by the airborne route. So let's have a look at standard precautions. Okay, we've already talked about hand hygiene. We're not going to go into too much detail about that. PPE, what's your standard PPE that you use? Yep, gown, goggles, gloves, mask. Yep, okay. So nothing special about that. Okay, and these are used for routine use. Okay, but you need to obviously, you don't put you don't put that all on just for everything. You need to actually use it as appropriate for the procedure that you're using. So you need to have some understanding of it. It's also important with PPE, and especially when you're doing your PPE for transmission-based precautions, that you have some posters up and some education about the correct way to apply it and the correct way to remove it. They call it donning and docking. So you can get posters. Here's a picture of one here that talks about the correct order for removing it. And where you have your PPE for transmission-based precautions, it's really useful to actually have a poster that talks in there with it about how to remove it properly. Okay, handling and disposal of sharps. Okay, what are some strategies for the safe handling of sharps in the primary care setting? What do you do? You don't recap, that's the same everywhere, yep. What else do you do in general practice a bit around sharps?
Doctors get rid of their sharps if they've used
Yes,
them last.
have a blanket rule, the person who uses the sharp disposes of the sharp. You know, don't ever find yourself putting away dressing post-procedures if there's still suture needles and things on there. Get the doctor back to throw that out, because you might not have actually watched the procedure, you might not, you know, they might always just use one suture, but on a particular occasion they've dropped something and they've opened two, you don't know about that, and so you're only looking for one and not two. So it's a pretty obvious rule that whoever uses it throws it away before they get you to clean up the rest of the stuff. What else do you do? Have your sharps containers where they're actually close to where you're using them. Now, there's no point doing something that uses sharps here and then having to walk across the other side of the room to dispose of the sharp, because people get lazy and they actually sit it down. And what do you do when you are carrying or walking with a sharp? What do you encourage people to use? What was that? Kidney dish, yep. Put it in a kidney dish. And
If you have to just pick it, like in a hospital, if someone drops on the floor,
yeah.
you just say, I have a sharp, so.
Don't go there. That's right, if you do happen to drop one. And then, of course, what about, I would say take extra care with procedures that are not performed routinely. Probably one of the most high-risk procedures, of course, is IV cannulation, and it's probably not done routinely in general practice a lot. GPs are not particularly skilled at it. They might be getting better now. We're doing more and more, you know, iron infusions and things, but just take extra care around your sharps where it's something like that that's high risk, you know, large bore needle directly into the vein, and it's not done often. Okay, what do we got next? Environmental cleaning. Okay, what about cleaning? How do you know what to clean in your practice? How do you know what's your responsibility and what's someone else's?
Generally, we take responsibility for your own area that you're working in, but
Yep.
then also the nurses, we generally go and clean the doctor's rooms at the end of the day as well.
Okay, so generally clinical staff clean clinical areas, unless it's, you know, obviously, and you say you clean your own areas. What about your other areas, like your routine cleaning? Is there a schedule there or a plan there that says how often something's going to be cleaned? Do you know in your treatment room how often your curtains are cleaned? I hope it's not every 3 years just before accreditation. Often it is, but I hope it's not. But, you know, be mindful of the things in your area. Actually have your head around how often are those things cleaned and changed. You know, is it on the schedule? Has someone forgotten about that? You know, so these are important things to think about. With environmental cleaning, again, keep it simple in general practice. You need to buy a medical grade product, but you try and avoid buying those products that require you to spray sprays on that then need a certain amount of time and contact, you know, some of your enzyme things, because nobody does it in primary care. No one has time. So it needs to be quick and it needs to be a one-off thing. And most of the benefit of cleaning is actually in the manual application, not the product that you're using. You know, in hospitals they're moving towards just using water and that. In primary care they're not moving so much towards that. As far as I'm aware, they're still using your Sonadette, your Clinadette, some sort of a detergent-based cleaner. And then also cleaning blood and body fluid spills. Make sure all staff are educated about how to do that. You know, it's not a lot of point if they just call the nurses to do it and then you're not there and there's a blood and body spill and the new girl in reception has never been taught how to clean it up. That's not fair to put her in that situation, her or him, and it's just not good practice. And obviously most places have a spills kit. Everyone got a spills kit around? Do you know, ever check the stock of the spills kit? Check what's in there? Have you had a look at what's in there? It's always worth seeing. Sometimes they have some of the most amazing stuff that you're never going to use, and you'll think, oh goodness me, I've got enough kitty litter here to, you know, for the whole RSPCA to use or whatever. You know, so, you know, and kitty litter, really there is better products now. You don't need kitty litter, there's other products around that work better. So just have a look at what's in there. And then of course we've also got your reprocessing of reusable instruments and items. Not going to go into that in a whole lot of detail, but I would suggest that if you are working for a service where you're sterilising items on site, you make sure that you get to a proper session or training session on how to do that, or there's some good things on YouTube as well QPA have some good YouTube videos that you can just watch any time, and I think APNA does APNA have some training and some videos and things on that as well. So if that's part of your role, make sure that you understand it and know the steps. It's important that it's always done the same way and that it's consistently applied with everybody. Respiratory hygiene and cough etiquette. Okay, what do you do there? Do you have any suggestions on what people are doing to manage that? We're sort of coming up to March. We're getting into flu season again.
Someone a mask.
Yeah.
Coughing.
Yep, ask someone to wear a mask. The reception staff will ask people to wear masks. Do most people accept that? Most patients are educated, they don't mind that. Yeah, that's generally what you find. What about, getting some of these posters and putting these up around? If you leave them up all year, no one notices, but if you kind of put them up seasonally, that can help a bit. Educating patients, having bins and hand rub and things handies, and encouraging people to wash their hands after they're blowing their nose. What about some other strategies to educate patients around their responsibilities? What else can you do?
Signage.
Yep, signage.
Just one-on-one.
One-on-one talking to them, that's right. Talking to someone, especially if you see that they haven't got very good habits or whatever, then yes, one-on-one. New mothers, that the mother's got a cold, talk to them about, risk of infecting their babies and things like that. What about your on-hold phone messages? It's always a great way. People have got no choice but to listen to that, so you can tell them all the information. They can't escape it. Up the back.
I've seen some clinics say you have televisions and they use that for sending messages. They might have like health coaching over the TV in the waiting room.
That's right. You can actually get them for free. The services that provide them will provide the TV for free, and then you can just put the messages on, and you can do some of your own as well. So they're worth looking into. Yeah. Okay, final one, aseptic non-touch technique, and that doesn't change. It's the same principles in the hospital or the primary care. You might find in primary care that GPs are a bit reluctant to use sterile gloves. A lot of them don't use sterile gloves as much. They'll just wear normal gloves, and if they are going to do that, if they've got a very strict non-touch technique, there's no evidence. We've got this thing, all the evidence and research is done in the hospitals, not in primary care. So doctors say, oh, well, it never happens. I never get infections, I worked with a doctor who liked to do his vasectomies just wearing normal gloves, I say, oh, shouldn't you wear sterile gloves? And he's quite a well-known doctor in the infection control area, and he quite assured me it wasn't necessary. It's hard to bring up the evidence when there isn't any. So sometimes you've got to pick your battles, and you think, well, you know what, if you want to do that, well, let's worry about something more important like proper hand hygiene before you put those gloves on and afterwards and things like that. But you will find there's lots of differences to what you might have seen in the hospital to what goes on in primary care, and lots of differences between how one doctor or one staff member works to how another works, and that's where you can try and get some consistencies if possible, but again, you've got to be realistic. So, waste. We haven't talked about linen and waste. Anyone here still using linen in their practice, or are you pretty much disposable? There's a few people nodding. Half and half. It's, really it's much better to go to disposable for all sorts of reasons. If you're washing linen, it's got to be washed straight away. It's got to be put in a separate container, and if it's got blood on it, marked as contaminated, etc. My suggestion, if you want to move away from linen, is just throw out anything with blood on it, so that then it doesn't get reused, and eventually they'll think, oh, we need to restock. Let's look at the equation of whether we get disposables instead. So sometimes that's the way, but don't get caught and don't say I told you that. And then you've got your two categories of waste. You've got clinical waste and general waste. Who wants to tell me about the two subcategories of clinical waste? What have we got? Clinical waste. It's either sharp or non-sharp. It's usually the way you look at it. Okay, so sharp's container, and then your yellow bins for your non-sharp. And then you've got your general waste, and it might be recyclable, non-recyclable, general waste. Now here's where it gets a bit tricky, because what you put in your general waste and what you put in your clinical waste, in the primary care setting, clinical waste costs a bit more to throw out than general waste. So there'll be a lot of pressure on you not to be putting things in clinical waste that could go in general waste. So you need to have a clear understanding of what's been decided around your practice, and you need to be mindful that what you decide is legal with your local council regulations. But the other thing to consider is it likely to cause public offence? So, for example, say your rubbish bins go out on your normal curbside collection for your general waste. If you're putting things in there that should somebody's dog tip that bin over in the night, are you likely to have a current affair on your doorstep saying, what are you doing throwing all this out? Okay. Now there's nothing to stop you from doing it, but it might cause public offence. Like if I'm at home, if I get a blood nose, I don't call in the clinical waste people to throw out my tissue. You know, I can just put that in normal waste. So you are allowed to put things with blood in general waste, but what do you do when you're in medical practice? Is it likely to cause offence or not? So who can think of some of the things that there's a few, probably some discussion or a little bit of a cringe factor of whether you put them in general or clinical waste? What sort of things are you using in your practice that people are not sure of? Okay, so a dressing that's blood soaked, where would you put it? Yeah, in your, if it's blood soaked and you could squeeze the blood out of it, it needs to go in your clinical waste. Okay, so again, it looks medical, doesn't it? It's got blood on it. You know, what do you do with that? Technically, it could go in general waste, but you might make a decision. I think we'll put it in clinical waste. What about your speculums? What do you do with them? Hey?
Put ours in the biohazard bin.
Yep. A lot of other services will put them in general waste, and because they're so big and so expensive, they take up a lot of space, they'll run the risk of it. What shouldn't be going in your clinical waste is paper towel when people wash their hands. You see that all the time because the clinical waste bin's handy. That's just a waste of clinical waste space. And so, you know, medications and drugs, they need to, well, ideally you should be putting them to the pharmacy, but if you can't do that, then you put them in your sharps containers normally rather than your normal waste. So you need to have a little think and be working as a team about what goes where with your waste, and it's again something that has to be worked out on a case-by-case basis. Okay, we're at the end of our standard precautions. Let's talk about our transmission-based precautions. And again, like I said, always look at these as, you know, there's these, 5 things that you can really do, and you have to select which ones of them. It's like a toolbox, you know, or it's like you're packing your lunch. You take what you want for the particular occasion. So you need to think, what's this infection? What do I need to protect myself? And how am I going to do it? So, but let's talk first about what these things are. So how does isolation and distancing of a patient look in the primary care settlement in setting? I mean, they're obviously working in the community, they're coming home. So how do you do this? What do you do? How would you achieve that in the clinic? If someone comes in and you know they've got something that they need to be isolated or distanced, how do you do that in your setting? Okay, so don't sit them in the waiting room, take them into their own room, yep. So an alternative waiting area or a little waiting area off to the side where they're not sitting close to everybody. What else would you do?
A mask.
Yep, ask them to wear a mask, okay. Wear a surgical mask. What else would you do?
Generally I inform the doctor, and that way it's quicker for them to generally see them where they are. If they're in another consultation room that's unused, that way you're not reinfecting another room. The doctor to see them where they are in the other consultation room, because then you only got one room to clean.
Yep, so you're not actually seeing them in one room and then walking them down to the reception area or the treatment area and taking them to the pathology. You know, you try and keep their care in one area. The other thing you might do is actually have a look at if there's any neonates or elderly patients that are in the waiting area as well, and think about where you might place them. So you might call them through to another room so they're not in the waiting room with it, so protecting other things. When we had the pandemic influenza, we just ran out of places to be able to isolate and distance people because everyone was just coming in with, you know, this influenza and no one knew what it was. So they actually would leave people sitting in their car, and people got mobile phones, and they'd say, hey, do you want to just sit in your car, listen to a bit of music on the radio, we'll ring you, or the doctor can come out and see you in your car. So sometimes you can think about doing that strategy. You can also think about home visits as well. So, you know, actually don't come in, we'll come and visit you at home. Okay, PPE, what do you do and what sort of PPE do you do different when we're talking about transmission-based precautions? Full-length gowns, make sure your arms are covered, and things like your P2 masks. Make sure, have a look, I'm not sure if I've got a P2 mask in here, yep. Okay, so you've got your normal surgical mask, you've got your P2 masks. They're often a duckbill shape, but not always. One thing they will always have on them is P2 on them to say that they meet that standard. Okay, you should have in your practice a little stockpile, a little box of actual items that are reserved for when you need to implement transmission-based precautions. So you should have a few P2 masks, you should have a few long gowns, and I mean, that's the main thing because you've got gloves and glasses normally, you can just use those. But just make sure you know where those things are in your practice and that you do have some stock of it and that it hasn't expired. And then what about providing patient dedicated equipment? How do you do that, do you think, in a GP setting? Any ideas? Not like the room where we can just lock them in there and say, there's your toilet, there's your bathroom, you know, we're going in to see you. It's a bit different to hospital, isn't it? How do you achieve that?
As far as possible, only use disposables.
Yep, use disposables whenever you can with that person. What else would you do?
You could dispose of any equipment, obviously not completely sterilised, but anything that you use on them, you put in a separate rubbish bag.
Yep. So empty the bin that you've used on that person. Say you're doing a dressing on someone with MRSA, you would empty that rubbish bin before the next person came in there, and you'd probably book them at the end of the day or the end of the morning session so that you've got time to clean before the next person comes in. So you plan their scheduling of their appointment. You might actually, rather than having them come in, if say they need a dressing every 2 days, you might actually teach them how to do their dressings at home, so they're only coming in once a week or something like that. Educate them about what they need to do, how to do it, and obviously you have to educate them about what to do at home and how to be mindful of what they're doing at home too with their waste from their wounds or whatever. So you have to think about that.
In general practice, implement RDNS.
Can you get RDNS to come along to do things, do you mean?
Go to their home instead of them coming in if they have an MRSA.
You can initiate it, but it's often not covered by anything. So it's because they come under hospital in the homes and they haven't been to hospitals, so it's often tricky. But you can try, and often if they're pensioners or whatever, they're able to get it, and sometimes their private insurance will let them. You wash anything contaminated last. So say you're washing instruments because you're reusing them. If it comes off that, you would either wash it in water of its own or wash it last. So, you know, you just work it, you do as much as you can, and next thing is your cleaning, two-step cleaning process. So again, that's around where you would increase the frequency of cleaning, you would enhance the cleaning. So you clean immediately rather than waiting at the end of the day. What are you doing in flu season? Do you clean more often? Yeah, you wipe surfaces more often, you wipe the tables down, you wipe the door handles down. You might not bother with that normally, so you enhance your cleaning process. You give patients education about the cleaning at home and perhaps using their own shower or whatever, rather than if there's an option of 2 showers in the house. And where there's a high suspicion of infection with a pathogen that's transmitted via contact, it's best to use a 2-step cleaning. So that's when you clean with detergent and then you might disinfect, and usually with alcohol wipe or something like that. I'm seeing a lot of those Tuffy wipes and those sorts of things in primary care. Just make sure that you're using a detergent wipe and not an alcohol wipe for routine cleaning. So the alcohol wipes that they will send you are for disinfectant. So they're for your 2-step cleaning, but it's your detergent wipes that you should be using routinely for your standard precautions. Sometimes people have mixed them up and they've ordered the wrong ones from the suppliers and they're using alcohol wipes instead of detergent wipes routinely. And then to restrict movement, we talked about that before, appointments at the end of the day, home visits and bypassing the waiting area. So we've covered all of what we have to do. Now we're going to talk about how you might implement all the things we've got in our toolbox when we're confronted with an infection, and how you make that decision, how you go about that. So no setting's the same. So therefore there's this criteria that's worked out around how to assess the risk and use that process and work through that process of what's appropriate for your area. That's not too distracting, is it, that noise out there? You're kind of okay with it? Good. So let's do some steps. There's actually a matrix and a process to do this because it is not possible to provide a one-size-fits-all approach to risk management. Okay? And it's best if you do this in advance of an event occurring. So you actually have this planned and you know what to do. So therefore, you're starting to gear up now and plan, what am I going to do for influenza season? You're going to have it in place, you're going to know. And so we're going to talk about that. We're going to use that as an example because it's actually quite appropriate and something everybody will have to do. So obviously we're going to look at your policies, your staff training, your reporting and your actions. So this is around looking at the steps and a little bit of a case study for you, just to keep you awake for the last 10 minutes. Okay, this is what it looks like. It doesn't need to be, it's not as complicated as it looks, but they call this a stepwise approach, and it's about being proactive rather than reactive. The first part about it is to identify your risks. So that's up here with, right? Establishing the context of your service. Well, for the purpose of this, we'll say we're a general practice, 3 GPs, couple of nurses, routine sort of layout, nothing, fairly modern, that sort of thing. Okay, with identifying, so this is the context we're looking at, with identifying your risk, there needs to be a process to identify the risks, and that's usually your surveillance activities, okay? You're surveying, you understand that, and I mean, Blind Freddie knows that we're coming into flu season, but we know that from surveillance, so you know, your other surveillance might be, hey, we've actually heard there's a measles outbreak, let's actually be prepared to implement this approach for measles should it come to us. Hey, we've heard that the rugby club's a nice haven for community-acquired MRSA. What are we going to do if someone comes here with that? Let's prepare for it and have it all mapped out. So this is what this process is about. Okay, then we're going to talk about avoiding the risks. So the first thing you're going to do is there any way that this risk can be avoided or eliminated? Can you just say, actually, we're going to make a blanket rule. Anyone who comes here with this, we're going to send them on to the hospital. Okay, a lot of people did that with the pandemic influenza. They just said, we don't have the capacity to deal with this. If we have anyone who rings up who says they think they've got that, we're sending them to the hospital. So, you know, you might avoid it, but more often than not, that's not an option. We've usually got to realise that we have to analyse the risk, it's going to happen, how are we going to manage it. So you generally use a risk matrix to analyse the risk. So let's, so I'll show you that in a minute. Then we're going to evaluate the risk, and that involves requiring what interventions you're going to do. Okay, so you've analysed it, and then you know you're thinking, what interventions will I do? And you need to do what will generally have the greatest impact and that's feasible to do in your environment. Okay, because there might be some things that are great to do, but it's just not plausible or not cost effective to do. But the thing that'll have the greatest impact is what you focus on. And then you're going to treat the risk. So you're going to decide what your management options are, talk to your other colleagues, use your own knowledge, and look at what's best practice and decide this is what we're going to do in our organisation when this happens. So let's have a little practice at how it would work. This is what a risk matrix looks like. You will have seen them everywhere. It's quite simple. You look at, well, we're going to do an exercise in a minute with influenza. So let's talk about influenza now. During the flu season, what would be the likelihood of someone coming into your surgery with active influenza? I'd say probably almost certain, don't you reckon? Okay, what's the consequences of having someone getting influenza? That's a bit tricky. For some people, it might be nothing, you know, a couple of weeks off work or whatever. But for other people, what are the consequences? Elderly, could be death, right? So we know it's almost certain, and even if it's minor consequences, we know we've got very high to extreme risks. So really tells us that influenza is something we need to actively manage and think about how we're going to manage it in our practice. Okay, so now I'm going to get you to have a little think about a case study here, because I think these things make more sense when you actually put them in the context. So we've got a typical GP service. We know that the risk of influenza during the flu season is obviously likely, and we know that it's got a rating of high or very high in terms of the consequences. It can't be avoided. So the next step in this framework is to evaluate the risk. This requires you to learn about the risk and identify the types of strategies that are going to be effective in breaking that chain of infection. Okay, so I'm going to ask you to evaluate the risk. Here's some really useful questions to be asking yourself. Right? Is influenza vaccine preventable? What transmission-based precautions apply? Is there any target group? Are there any special requirements? What's the recommended duration? Now, if some of these things you'll know, but sometimes you actually think, oh, I'm not really quite sure about that. I didn't listen that much in microbiology. So you can go to page 165 of the NHMRC guidelines. It's online and it tells you about all these things and essentially answers these questions for every type of disease you can think of that's infectious. So, but today you haven't got the benefit of that, no Googling. You need to actually answer these questions. So just talk to the people next to you for a couple of minutes, and I want you to write down, think about the answers to those questions, and then we'll talk about them. Okay? Okay, first question. Is influenza vaccine preventable disease? Yes? Okay, so you're going to be pre-flu season, making sure you vaccinate as many people as you can because that's just going to make your life easier down the track. Okay, are standard precautions sufficient to manage influenza during the outbreak? If you have someone with influenza, are standard precautions enough, or do you need to have transmission-based precautions for influenza? Yep, you need transmission-based precautions. Okay, what transmission-based precautions are required for influenza? Okay, put them into those categories. Remember we talked about the types of precautions. We'd be looking for contact precautions and droplet precautions, wouldn't we? So what would that involve? Mask, someone said, which is a droplet precaution. What else would you have? Isolation and distancing for your droplet. What else would you have for your contact precautions? Gown and gloves. Hand washing, yep. What was that part? So? Cough etiquette, yes. What else would you be doing? Extra cleaning, extra surface cleaning and environmental cleaning. Okay. Now influenza isn't traditionally listed as requiring airborne precautions, right? But often, and especially during the pandemic outbreak, we recommended that people wore P2 masks when they were doing like throat swabs and procedures where they were close to someone with influenza. And the reason for that is because during the pandemic season, we actually it wasn't a vaccine preventable influenza that we were dealing with. We knew that the vaccines weren't working for it. So that's why people had to wear these and wear full airborne precautions, because they weren't able to be vaccinated for it. So you would only really consider airborne precautions around if you were unvaccinated yourself for influenza, and if you were having to do something where you were within a metre or in close proximity to somebody with influenza. Otherwise, if you've had the vaccination and you've had regular flu vaccinations, unless there's some emerging evidence that the outbreak that's prevalent in the year wasn't covered in this year's flu vaccine, you wouldn't worry about airborne precautions, but they may be relevant. So that's where you need to make a decision based on what you know in the current situation. Is there any target group of patients that these precautions must be applied to? Yep. 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 And during the pandemic, or during the flu season, it's probably nearly everyone, because everyone who's not immunised pretty much, but yes, there is special things for your elderly, your pregnant, your Indigenous and those sorts of groups, which you hope that you've already covered off with your vaccination pre-season if you can. Okay, and of course you're immunocompromised, because sometimes, especially maybe people that have got cancer, they weren't planning on becoming immunocompromised. They might not have known they were going to get cancer, you know, and they haven't had their flu vaccination. Okay, what's the recommended duration of precautions for influenza? Anyone know?
I'm not sure of the wording of the question.
Okay, so I guess when someone has influenza, what's the time when you are most prone to be spreading it or catching it? How many days?
First 3 to 5.
Yep, you're right on, very good. It's the first 3 to 5 from the onset of the illness, and it can be longer in children. So that pretty much tells you, given the volume of people that go through general practice, given the incidents that generally get influenza during the season, you're going to pretty much have someone every day come in that's probably, even if they're not diagnosed, will have influenza, you know, and be in that stage where they're able to transmit it. Okay, and then, so in summary, what do we know about influenza? Okay, we know that in addition to standard precautions, contact and droplet precautions are required. We know that we need to apply it to all infected patients, and there are special requirements for non-immune or immunocompromised and for pregnant healthcare workers and patients. We also know that it's vaccine preventable. We know that it's common and it's highly transmissible, and we also know that many infected patients will present within the time frame of when precautions are required. So that's just your big summary in our head. The next stage of this risk evaluation is actually to look at, well, given what we know, actually how are we going to treat it? What are we going to do in our medical service to make this safe? So have a discussion about how you're going to treat it, and these are the questions that you're going to ask yourself to think about how you treat it, how you identify the patients, how will you communicate and activate the treatment plan, and what are your strategies for, you know, what are you going to do for hand hygiene, PPE, cleaning to contain and confine the infection, for patient education, for protecting staff and protecting other patients, and how long do you have to do it for? So this is what we know about influenza. What are we going to do about it? So have a little chat for a couple more minutes and we'll come back and talk about it. Okay, so the first thing is, how will you identify infected patients? Whose responsibility is that, and how are they going to know what to look for? It is everyone's, yeah. But in the front line instance, who's probably going to be having most of the? That's your reception staff. And how are you going to make sure that they know what they're looking for and what they have to do? You're going to educate them, and you're going to remind them that this is something to look out for, etc. The next thing is, how are they going to communicate to activate the treatment plan, or how are they going to communicate that they've got someone in there who clearly looks like they've got active influenza, so you can implement what you need to do? How's that? What's some strategies or ways that could happen?
They can alert us on the computer software.
Yep, so they could send an email to the nurse to say, hey, I think this person needs to be taken to a room by themselves or something, and in the interim they might put a mask on the person or something. Is that the most common way that it would be communicated, just via the email or something like that? Come and tell you? Yeah. So as long as it's thought about how that is going to be communicated. What about if someone actually makes it to the doctor's room? How's the doctor going to let people know? Or do they need to let people know? You need to think about this. Do they need to let people know, or can they just treat the person and, is that enough? So you need to think about what your processes are. And it will be different for each service. Now, what are your strategies? What are you going to do around hand hygiene? What things are you going to do?
Put out more hand sanitizer everywhere.
Yep, put hand sanitizer everywhere with signs encouraging people to use it, especially as they're coming in. Okay, what else are you going to do around hand hygiene? Remind staff to wash their hands more, and you'll probably, that's probably the main thing, increase your hand hygiene and put some alcohol, some hand rub in the waiting area. What about your PPE? What are you going to do there? Make it easily accessible. Make sure you have it. Check that you've actually got some, and it's a good time to check that you've got your transmission-based PPE. Put some masks at reception so that the receptionist can give those to people that might be coughing and spluttering. So think about that. What are you going to do around your cough etiquette? Things like that.
Poster. Just a poster.
Poster. You might. What other things could you do around cough etiquette?
Actually have an active discussion with your patient about it.
Yep. Educate. A bit more focus on educating patients, or give them a little leaflet when they're there. Yeah. You might put rubbish bins and tissues around more, so that people are not having to, sneeze on the thing and put it back in their pocket, and then when they get to reception, pull out the Medicare card and unwrap the tissue from it, and these sorts of things that happen all the time that are pretty gross. So think about that. What are you going to do around your cleaning? Are you going to do any extra increased cleaning, and what's that going to look like?
My boss just said before, cleaning the bench top at reception,
Yep.
where they're pulling out their tissues.
Yep.
Leave the wipes thing there for admin to be able to clean that multiple times a day.
Yes, clean that and clean the pens. People are signing for their bulk billing. Yep. What other things? Sorry, what was that?
Clean the chairs.
Clean the chairs, arms on chairs, and just generally other surfaces around and things like that. What are you going to do with kids' toys and things like that? Don't have them or put them away. Yeah. So think about that sort of thing, especially you might have them out of the waiting room, but often they're in other rooms and doctors' rooms and things like that. So you have to think about those. What about protecting the staff? What are you going to do with your staff? Vaccinate if they are. If they're not going to be vaccinated, work out strategies with how you manage that and what they're going to do, and make sure they're aware of their responsibilities. So that's pretty much what you do, and you would write that up. And what's the duration? How long are you going to probably do that? I'd say in flu season, given that the 3 to 5 days, one per person, you're just going to do it as a routine for the few months of flu season. I don't think you've got a lot of choice, but that becomes your routine practice for a while. Okay, so we're nearly at the end. So I think what I hope your real take-home message from this is that it's not just about looking at what you do as an individual around infection prevention and control. It's actually your individual responsibility, and then the other people in the practice, and then the patients and community. So I always get people to say this at the end, because I really think this is your take-home message, that if you want effective prevention, if you want effective infection prevention and control, then you need to say this: say it with me, infection prevention and control is everyone's responsibility. And I think that's really the take-home message from this. I think the next slides are just about some useful websites, which you'll have. ongoing learning, and thank you. Thanks for that.